I'm Dr. Isa Muhammad, a consultant radiation oncology at King Hussein Cancer Center in Amman, Jordan. I will be discussing radiotherapy for early stage laryngeal cancer. In the next 25 minutes, I will discuss key anatomical features important for understanding laryngeal cancer and its treatment, explain the diagnostic process for early stage disease, discuss the staging criteria and its significance, and treatment planning, outline the various treatment options for early stage laryngeal cancer, emphasize the role of radiotherapy in the treatment plan, discuss the radiation doses and the fractionation schedules used in treating early stage laryngeal cancer, and explain the rationale behind the chosen doses and schedules. Then I will describe the different radiotherapy techniques available and define the target volumes for radiation therapy. Then I will conclude. I will start with the normal anatomy of the larynx. The larynx is a small anatomical structure. It's divided into three anatomic regions: the supraglottis, glottis, and subglottis. Supraglottis is divided into epiglottis, area epiglottic fold, the area of arytenoid, supraglottis, and the area of ventricle. Then the glottis is divided into right true vocal cord, left true vocal cord, anterior and posterior commissure. Then the subglottis extending from the lower boundary of the glottis to the lower margin of the cricoid cartilage. Staging workup and the pre-treatment evaluation of early-stage laryngeal cancer should include complete history and physical examination, including fiber optic laryngoscopy. You need to document the location of the tumor, extension, the mobility of the vocal cord. Also, it's very helpful to record the fiber optic video. You can have a look during GTV contouring during radiotherapy planning. Then once the mass is identified, you need to send your patients for DL and biopsy to confirm the presence of SCC. Once SCC is confirmed, you need to order next CT scan with IV contrast to rule out endophytic extension of the tumor, to rule out paraglottic, preepiglottic, and thyroid cartilage extension. CT chest, it's not necessary for actually T1, T2 glottic cancer, but once we are speaking about supraglottis and the glottis, and given the significant smoking history of our patients in our region, so in my practice, I do order CT chest to rule out second primary lung cancer in these patients. Then pre-treatment evaluation also for smokers should include smoking cessation counseling and also pre-radiotherapy dental evaluation. Also, it's very important to engage your nutrition, speech, and swallow team during and after radiation therapy. So once the workup is completed, you need to document the final stage based on the TNM staging system, 8th edition. So staging for T1, T2 glottic larynx cancer, T1A, the tumor is involving one vocal cord with intact mobility. T1B, tumor involving both vocal cords with intact mobility. T2, tumor is involving one cord and extending to supraglottis or subglottis, or any tumor with impaired mobility. Staging of supraglottic larynx, T1, tumor involving one subsite with intact mobility, for example, false cord with intact mobility. T2, tumor involving two subsites of the supraglottic larynx, for example, false cord with epiglottis with intact vocal cord mobility. Or tumor involving regions outside the larynx, for example, vallicula or medial wall of pyriform sinus. Regarding the staging of the subglottic larynx, T1, tumor limited to subglottis. T2, tumor extends to vocal cords with normal or impaired mobility. Let's move to treatment options for T1, T2 glottic cancer. Treatment options include either transoral laser surgery or radiation therapy, and with the radiation therapy we have too many options. I will discuss later in my presentation in the technical part. In the literature, we have only small randomized trial comparing laser surgery with radiation therapy. They evaluated voice quality after treatment with radiation versus laser. They included patients with T1N0 glottic SCC. Radiation was 66 degree and 33 fractions over 6.5 weeks using the Hanka schedule versus transoral laser surgery. Voice equality was evaluated at the baseline and 6 months and 24 months post-treatment. And the main outcome was physician-reported and patient-reported voice equality. Regarding the physician-reported voice equality, they reported the quality of the voice in terms of grade, roughness, breathiness, asthenia, and strain, while patients reported voice equality focused on hoarseness and impact on everyday life. The results of this study showed that both treatment options, radiation and laser, showed similar two-year local control. However, transoral surgery reported more breathy voice and wider glottal gap, while patients who received radiation therapy reported less hoarseness and related to inconvenience in daily living at 2 years. Several meta-analyses compared radiation versus transoral laser surgery and showed that both options reported to have equivalent oncological outcomes in terms of local control. However, most appears to favor radiation in terms of voice equality for larger tumors or tumors involving anterior commissure. For T1A, we prefer transoral laser surgery over radiation therapy for tumors not extending to anterior commissure, as anterior commissure is difficult to clear oncologically, and anterior glottic web may occur, which subsequently will impact the voice equality in this highly curable disease. This is a prospective observation cohort study from UK, evaluated patient choice in the treatment of early stage laryngeal cancer, comparing treatment choice of radiation versus transoral laser surgery. This study included patients with T1, T2 glottic SCC. In this study, patients were seen in the joint clinic together with head and neck surgeon and radiation oncologist. 51 patients were directed towards radiation by the medical team. They were only eligible for radiation therapy alone, while 47 patients were eligible for both surgery and radiation therapy, and these patients were given a choice between radiation versus transoral laser surgery. Interestingly, 60% of patients choose transoral laser surgery, and this difference was statistically significant. So it's very important when you have a patient eligible for laser and radiation to be seen jointly with head and neck surgeon to address the advantages and disadvantages between radiation and laser, and based on patient's factors, the tumor factors, and availability of expertise, then you select the appropriate treatment for your early stage laryngeal cancer. Radiotherapy outcomes for early glottic cancer. The 5-year local control rates for T1 disease, it's ranging between 85 to 95%, while for T2 disease, 60 to 80%. Actually, T2 is a heterogeneous group, and that's why you see this wide range between local control ranging between 60 to 80%. And the 5-year overall survival rates is more than 90%. When you treat these patients with radiation therapy, we don't electively irradiate the neck given the low incidence of nodal spread. So let's move to the radiation dose and the fractionation schedule for T1 glottic cancer. So data from Osaka, Japan, published by Yamazaki et al. Evaluated the effect of radiotherapy fraction size and overall treatment time on the local control of early stage glottic cancer. Patients with T1 glottic SCC were randomized to 2 gray per fraction versus 2.25 gray per fraction. Patients with minimal tumor that involving less than 2/3 of the true vocal cord were randomized to 60 gray in 30 fractions versus 56 gray, 0.25 gray in 25 fractions, while tumors that involving 2/3 or more of the true vocal cords were randomized to 66 gray in 33 fractions versus 63 in 28 fractions. And there was a clear win. Arm B, the 2.25 gray per fraction, had 15% improvement in local control compared to Arm A conventional fractionation. And there was no statistically significant difference between two groups in terms of acute toxicity. Another study from Korean Radiation Oncology Group 0201 had the similar clinical trial designed to Yamazaki, but included patients with T1, T2 aggluttic cancer. These patients were randomized to 2 gray per refraction versus 2.25 gray per refraction. T1 patients received 66 gray and 33 fractions versus 63 and 28 fractions, while patients with T2 disease received 70 gray and 35 fractions versus 67.5 and 30 fractions. Initially, they aimed to recruit 282 patients. However, this study closed prematurely, and they were able to recruit only 156 patients. But they did subgroup analysis for T1A disease, and they reported the 5-year local progression-free survival for this group of patients, and they found that patients who received 2.25 gray per fractions, they had a trend towards improvement in local control compared to 2 gray per fraction, but this was not statistically significant. The p-value was 0.056. So from Korean Radiation Oncology Group and the Yamazaki trial, we can conclude that for T1 disease, 63 and a 28 fraction is one of the standard of care radiation doses for early stage glottic cancer. Another important trial is the HANCA-6. This is a phase 3 randomized clinical trial of glottic larynx. Included patients with non-metastatic stage 1 to 4 laryngeal cancer. However, the most of the patients had T1, T2 disease, were randomized to 6 versus 5 fractions per week to the same total radiation dose. And the patients who benefited from treatment intensification the most were patients with early stage well-differentiated tumors. The hazard ratio was for this group of patients is 0.42. However, for non-well-differentiated tumors with T1, T2, the hazard ratio was 0.6. And if you look at the local control for patients in this trial, you can see that patients who had 6 fractions per week, they had 8% inferior local failure than those who had 5 fractions per week. And this benefit was not only at the 5 years, also at 10 and 15 years of follow-up. Another trial is R2G 9512. This is a phase 2 randomized clinical trial of T2 glottic larynx. Randomized patients to 70 gray and 35 fractions versus 79.2 and 66 fractions using 1.2 gray per fraction BID. So this study showed 8% superior local control for hyperfractionation at 5 years compared to standard fractionation, but this benefit was not statistically significant. Japanese Clinical Oncology Group 0701, this is a phase 3 randomized clinical trial of hypofractionation, 2.4 gray per fraction versus 2 gray per fraction. This trial included patients with T1, T2 glottic larynx SCC. T1 patients were randomized to 66 gray and 33 fractions versus 60 and 25 fractions, while T2 patients were randomized to 70 gray and 35 fractions versus 64.8 and 27 fractions. As you can see, patients who received hypofractionation, the red line, they had 8% less local failures compared to patients who received conventional fractionation at 7 years. And toxicity was less with hypofractionation. And this trial was showed superior results for hypofractionation over conventional fractionation. The next topic is radiotherapy techniques. While opposed lateral beams have a long history of radiation treatment, and we know that doses to the carotids between 35 to 50 gray have been associated with carotid vessels wall thickening. Recent data suggest a small risk of cerebrovascular events with two lateral opposing fields compared to laser surgery. A study from SEER indicated 1.75 times higher risk ratio with radiation compared to laser resection. This data was confirmed by authors from Ontario and showed increased risk ratio of 1.7 for two lateral opposing compared with transoral laser surgery. These findings have generated greater interest in IMRT. A study from MD Anderson compared the traditional to lateral opposing fields with whole larynx IMRT, and this was a dosimetric study. Looked at the dose distribution and clearly identified that whole larynx IMRT is associated with statistically significant reduction in V35, 50, and 63 compared with two lateral opposing fields. Clinical data from Memorial Sloan Kettering looked at conventional radiation therapy versus carotid-sparing IMRT, and clearly showed that patients who received carotid-sparing IMRT, they had similar local control at 3 years to patients who were treated with conventionally fractionated radiation therapy, suggesting that whole larynx IMRT is a safe radiation treatment. So let's move from whole larynx IMRT to partial larynx IMRT. And we know that reducing radiation volumes is associated with improved acute and late radiation side effects. Also, we know that mean dose to the larynx above 45 gray and mean dose to the non-involved vocal cord above 50 gray are predictors of grade 2 and above laryngeal edema and associated with worse voice outcomes. But this transition should be safe and should maintain similar local control. So a dosimetric study from Netherlands evaluated a single vocal cord irradiation in T1 glottic cancer. It showed adequate tumor coverage with excellent homogeneity of the BTV. And this study also demonstrated that partial larynx IMRT is associated with reduction of the contralateral vocal cord and arytenoid, contralateral carotid and thyroid gland doses, suggesting that dosimetrically there is a benefit from ipsilateral cord irradiation, but this should be also confirmed by clinical outcomes. The group from Erasmus Medical Center has reported the clinical outcomes from retrospective analysis of 30 patients with T1A and 0 glottic cancer treated with vocal cord only radiation therapy, and they compared the results of vocal cord irradiation only to a similar cohort treated with complete larynx radiation therapy with IMRT. They reported excellent 2-year local control as well as lower acute toxicity and improved voice outcomes at the end of radiation therapy 6 to 12 weeks at 6, 12, and 18 months post-radiation therapy, as you can see at the voice handicap index chart here. Vocal trial is a prospective phase 2 randomized clinical trial comparing vocal cord only versus complete laryngeal irradiation. The primary objective of this trial is to assess efficacy and safety of vocal cord radiation versus complete larynx radiation in T1N0 glottic SCC. The primary endpoint is local control at 2 years post-radiation treatment, and this trial has many secondary endpoints that also focus on the function post-vocal cord irradiation versus complete laryngeal irradiation. So hopefully we will learn from this trial in the near future, and hopefully this trial will set the vocal cord irradiation as a standard of care radiation technique for T1N0 glottic SCC. Now let's move to the technical part of this presentation. We'll start with CT simulation. We simulate our patients in the supine position. We customize the thermoplastic head and neck mask to take the shape of the head and neck and upper chest region. We give IV contrast. We simulate them we scan them with 2 mm slice thickness. Then we transfer the CT images to the planning software to start the planning process. So according to ICRU, you need to define your GTV, CTV, and BTV. You need to contour your organs at risk, and you need to add some planning organ at risk volume. So GTV, by definition, or gross tumor, it's not only what you see in diagnostic imaging. In early stage laryngeal cancer, you only see thickening, regularity, and you see just some small areas of enhancement. So it's very important to rely on a clinical examination, including laryngoscopy. Then you add a clinical target volume margin where you think that there is a microscopic disease. Then you add your setup margin. So if you're going to treat early stage glottic cancer, you need just to contour organs at risk located 2 cm above and below your target. You need to contour the spinal cord. You need to add 5 mm BRV margin. You need to contour right and left carotid, right and left submandibular glands, esophagus and thyroid gland, and non-involved vocal cord. When you do epicordial irradiation. When you have T1, T2 supraglottis or subglottis, then you need to expand your organs at risk to include more organs that you want to spare from radiation treatment. How I do carotid sparing IMRT in my practice for T1 glottic SCC. I follow the international consensus guidelines delineation of the primary clinical target volume in laryngeal cancer. I start contouring with the GTV definition. As you can see in the fiber optic, the tumor is involving the anterior 1/3 of the left vocal cord extending to anterior commissure and involving the anterior part of the right vocal cord. Then you go to your CT simulation image, you contour gross tumor volume. As you can see in this CT cut, you gather all information from fiber optic, CT image, and diagnostic imaging. Once you're happy with the GTV contouring, you verify your GTV in all CT simulation views, transverse, sagittal, and coronal. You make sure that you're not missing any part of the tumor. Then you need to define your clinical target volume. In early stage T1 glottic cancer, it's optional to define only 1 or 2 clinical target volumes. If you decide to define only 1 clinical target volume, then it's your high-risk clinical target volume. And according to this nomenclature, it's CTVB1 representing in a blue line. As you can see, the blue line created by expansion of the GTV in red by 5 mm margin. Then you can see that the blue line is overlapping with low risk areas for microscopic disease and high risk areas for microscopic disease. So then you need to get your final CTVB1 representing in yellow line by editing your initial CTVB1 by exclusion of the low-risk areas of microscopic disease. So you edit for the strap muscles, you edit for the thyroid cartilage, and then you leave the areas at high risk for microscopic disease in the vocal cords. Then you add your setup margin. Another example of carotid sparing IMRT for T2 glottic SCC, you start with the GTV definition, you contour your GTV based on the fiber optic findings. As you can see, the tumor arising from the right vocal cord, extending to anterior commissure and involving the supraglottic larynx. You contour your GTV based on all information. Then you need to define your clinical target volume. You have 2 volumes, CTV that will receive 56 or CTV-B2 and CTV that will receive 70 gray or CTV-B1. So you start with the CTV-B2 that will receive 56 gray representing in the blue line, which generated by expanding the GTV by 10 mm margin. Then you need to edit this CTV by excluding the strap muscles and the air. You keep the thyroid cartilage in T2 for a reason that the next stage is T3, and in T3 by definition the tumor is invading the inner cortex of the thyroid cartilage. So thyroid cartilage is at risk for microscopic disease. So then you need to define your CTVB1 that will receive 70 gray representing in yellow. How you get yellow contour? You expand your GTV by 5 mm margin by excluding CTVB2 or CTV56 gray. Then you add your setup margin. And during CT simulation and the treatment delivery, it's very important to instruct your patients not to swallow. Swallowing motion can be 2 cm in the superior direction. It's rare, rapid, and easily suppressed by patient, and it's associated with negligible impact on radiotherapy dose delivery. Another motion is respiratory motion, reaching up to 6 mm in sub-lymph direction and 2 mm in the anterior-posterior direction. So you need to think about adding ITV. But this is still not standard and something that we need to think about and develop in the near future. During treatment, you need to do daily CBCT and image matching with a laryngeal match rather than bone match. We know that there is a substantial positional discordance between cervical vertebrae, and larynx could be occur between radiotherapy fractions. Data from Princess Margaret Hospital confirmed that soft tissue mass is associated with superior local control compared with bony match. Now let's move to supraglottic larynx. Treatment options is either radiation to primary with elective bilateral neck irradiation, as supraglottic is associated with a high incidence of nodal spread. The recommended technique is IMRT, and fractionation is altered fractionation schedule. The other option is endoscopic or partial open laryngectomy plus neck dissection. SEER database showed that surgery improved 5-year disease-specific survival compared to radiation therapy. In some situations, when you get positive margin after endoscopic or open laryngectomy, you need to consider radiation therapy for a closed margin, presence of BNI and LVI, and chemoradiation for positive margin. This is an example of target volume delineation for T1 supraglottic larynx. You need to define two volumes, one for primary, one for elective neck. You start with the primary, you contour the GTV. As you can see in the FOL, the tumor is involving the right false chord. You contour your GTV, then you create your CTV-B2 low risk that will receive 56 gray, representing in blue. This created by expanding the GTV by 10 mm before editing. Then you need to create your final CTV-B2 or 56, representing in green after editing for air cavity, thyroid cartilage, and strap muscles. Then you need to create your CTV-B1 that will receive 70 gray and 35 fractions using the Hanka schedule. This created by expanding your GTV primary by 5 mm, excluding your CTV-B2 or CTV-56. Then you add your setup margin. And according to international recommendation for T1N0M0 supraglottis larynx, it's recommended to include level 2, 3, and 4A at the both sides of the neck. I start contouring of level 2 at the level of the transverse process of C1. Medially, I stop at the medial border of internal carotid artery. I contour the fibrofatty tissue located between the inner edge of the posterior belly of the digastric, sternocleidomastoid muscle, and paraspinal muscles. Posteriorly, I stop at the posterior border of the sternocleidomastoid, and anteriorly, I stop at the posterior border of the submandibular gland. This level ends at the level of at the bottom level of the hyoid bone. Then I start contouring of level 3. The anterior border of level 3 is the anterior edge of the sternocleidomastoid muscle. The posterior border is the posterior edge of the sternocleidomastoid muscle, and the medial border is the middle part of the carotid. So you contour the fibrofatty tissue located between these anatomical structures, cut by cut, until you reach the thyroid cartilage. You stop there, then you start contouring of level 4A. The boundaries of 4A is the anterior border of the sternocleidomastoid muscle. Posterior edge is the posterior order of the sternocleidomastoid muscles, and the medial border is the medial edge of the carotid artery. You contour the fibrofatty space between these anatomical structures, cut by cut, until inferiorly 2 cm above the maniabrum sterni. Treatment options for supraglottic CA is either radiation therapy to primary with elective bilateral neck to level 2, 3, 4, and 6A. We use IMRT with altered diffractionation. The other option is to go for total laryngectomy or extended partial laryngectomy with neck dissection. Adjuvant radiation therapy, usually post-surgery, is considered for a closed margin, presence of BNI and LVI, and adjuvant chemoradiation is for positive margin. During radiation therapy, we see early-stage laryngeal cancer patients weekly to manage acute side effects. Post-radiation, we see them initially 2 weeks post-radiation therapy, then Q 3 months or more frequent for 2 years, then Q 4 months or more frequent for third year, then Q 6 months or more frequent for years 4 to 6, then annually for years 6 to 10. We follow up them with fiber optic and we order imaging as clinically indicated. In summary, radiotherapy is a valid option for early stage glottic cancer, especially with anterior commissure involvement. Carotid sparing complete larynx IMRT with daily image matching yields excellent local control rates. Vocal cord only radiation is promising but needs further study. A randomized trial is underway. IMRT with altered diffractionation is a valid option for supra and subglottic larynx cancer. Thank you for your attention and hopefully we will meet in the near future face to face.